Okay, this is going to be the in-class version of alterations in oxygenation. So this is where we normally have our discussions and review questions, etc. But we're going to do the best we can. So this is our NCLEX style question, and the question is, the home health nurse is visiting a client with obstructive or chronic obstructive pulmonary disease, or COPD. Which nursing action is appropriate to implement for a client who has an impaired breathing pattern due to anxiety? So basically, we need to ask, first of all, what is this question asking? Okay, after you've thought about it for a second or two, what I came up with is, how do we help COPD clients with their breathing pattern, which is usually too fast? Let's look at the potential issues or potential responses. But before we do that, think about different ways we can help slow breathing down. Being a childbirth education instructor, I frequently told my uh, expectant coaches that they needed to get in the expectant mom's face sometimes and get their attention and ask them, breathe with me, and then actually go through the breathing motions. So you're showing them exactly what it is you want them to do. If you're just standing there coaching, slow your breathing down, slow your breathing down, they don't always really follow along. But if you're doing it with them, they can mimic that motion a little bit easier. So, these potential responses are to titrate the oxygen to keep the saturation at least 90%, teach the client how to use the pursed lip breathing technique, discuss a high protein, high calorie diet with the client, suggest the use of over-the-counter sedative medications. Okay, so let's look at each one of these. Titrate the oxygen to keep the saturation at least 90%. You know, it's really not a bad idea, but we also need to realize that sometimes our COPD clients may live at 88%, and if we get them up to 90%, yeah, that's great, but they're perfectly normal at 88%. So, yes and no on number one. Teaching the client how to use the pursed lipped breathing. Remember, this is where we have them take the big deep breath in and kind of purse their lips like they're getting ready to kiss someone and blow the air out through that smaller hole. Um, and that does slow breathing down. It also helps expand that alveoli. Discuss a high protein, high calorie diet with a client. Um, little concerned about the high calorie because a lot of times that high calorie has to do more with the simple carbohydrates, which is more of the sugars. If it were complex carbohydrates, that would be good. And remember, our clients are going to, COPD clients are often going to be a little bit anorexic because of the amount of energy it takes to eat and the amount of energy it takes to breathe. So they don't eat that much. But is that what the question is asking? Which nursing intervention is appropriate to implement for a client who has an impaired breathing pattern due to anxiety? I don't think the diet is going to actually affect that question. And then number 4, suggest the use of over-the-counter sedative medications. Uh, we can slow the breathing down with that over-the-counter sedative medications, but is that really appropriate for this client? They're already having dyspnea because of the inability to blow out the carbon dioxide. The sedatives are going to slow down the breathing, and they're going to retain even more carbon dioxide. So looking at this question, I'm going with number 2. Number 2 would be very appropriate. Okay, so we're going to do our next gen case study. Uh, the nurse is going to be working in a healthcare provider's office caring for an older adult female accompanied by her caregiver who provides a history of upper respiratory symptoms for 1 week. So this client is an 84-year-old white female who's widowed and a retired bank manager. She does have a caregiver that lives in her home, and this client uses a walker and takes daily strolls to the park with her caregiver. She is able to perform most activities of daily living. However, the caregiver prepares all of the meals. The client presents to the clinic accompanied by the caregiver that reports she's had a 1 week history of upper respiratory symptoms and a 2-day history of increasing weakness and malaise. About 3 days ago, the client developed a cough that has gradually become worse last night, and she nearly fell while going to the bathroom. She's been coughing up a significant amount of phlegm that is thick and green in color, and she has no fever. The caregiver has become concerned about the client's reduction in daily activities and her inability to get rid of her cold. So once again, this client has a 64-year history of cigarette smoking, chronic bronchitis for about 13 years, urinary overflow incontinence for 10 years, and was diagnosed with hypertension 6 years ago. Her blood pressure has been averaging 140/80s, and that is with medication. She suffered a cerebrovascular accident, or CVA, 4 years ago, and has mild left hemiparesis. She did receive her influenza shot 3 months ago. Her routine medications include atenolol, hydrochlorothiazide, aspirin, nortriptyline, Combivent, albuterol, and docusate sodium. She does have an allergy to penicillin. Her blood pressure currently is 140/80 with no orthostatic changes noted. She is 5'10" and a half. Heart rate is 95, regular, weight is 124, respiratory rate is 38 and labored. Her temp is 98.3. Oxygen saturation is 86% on room air. This client is a lethargic, frail, thin woman that's oriented to self only. The client also complains of coughing and using those accessory muscles to breathe. She is in moderate respiratory distress with nasal flaring, warm, clammy skin, eyes are watery. She's got some purulent discharge from the nose. Her ears have slight serous fluid behind the tympanic membranes. The pharynx has erythema with purulent postnasal drainage, and inflamed mucous membranes are also inflamed. Her breathing is labored with tachypnea. Her lungs have crackles and diminished breath sounds in the bilateral upper lobes and absent breath sounds in the bilateral lower lobes. And her heart does have a regular rate and rhythm. This is what her labs and diagnostic tests look like. Her sodium is 141, potassium 4.5, calcium is 8.7, magnesium 1.7, fasting glucose is 138, hemoglobin 13.7, hematocrit 39.4, white blood cell count is 15,200, BUN 16, and creatinine is 0.9. Her chest x-ray do reveal consolidation of the anterior inferior and superior segments of bilateral lower lung lobes with developing consolidation of bilateral upper lobes. Okay, so question number 1. As the nurse reviews the client's medical record, the nurse is aware that the client's history of what 2 things increases her risk for pneumonia? So fill in the blanks. This would be her smoking and her chronic bronchitis. So now we're going to look at these questions. The nurse is reviewing the client's assessments and findings. We need to indicate which assessments and which findings are consistent with pneumonia or other issues. The white blood cell count of 15,200, is it consistent with pneumonia or something else? This would be pneumonia. The fasting glucose of 138, pneumonia or other issues. This one is other issues. Oxygen saturation of 86%, pneumonia or other issues. Definitely pneumonia. Blood pressure 140/80. This one is other issues. BUN of 16. This one also is other issues. Green sputum, pneumonia. Respiratory rate of 38. This is pneumonia also. Oriented to self only. Remember, she's 86 years old, and our older adults, a lot of times the way they exhibit infectious symptoms is confusion. So oriented to self only would be the pneumonia. And crackles in the lungs. This is going to be pneumonia. Okay, so the nurse understands that what and what should be treated to prevent complications. The tachypnea or rapid breathing and the hypoxia, the lack of oxygen, is going to be what we need to look at. So the client will be admitted to the hospital for further care and treatment, but due to the client's assessment and symptoms, the nurse will implement measures to help keep the client safe. So now we need to determine what interventions are going to be increasing this client's safety or decreasing her safety risk. Frequent visualization of the client. Is this appropriate to improve safety measures? Yes, most definitely. Room close to the nurse's station? Again, yes, we want to do this. We want to keep eyes on this client. Soft vest restraint. Restraints are going to be absolute last resort, and it's so many things that we have to do with restraints that it almost makes it too much work to do, put it that way. But again, should be last result or last resort. Call light within reach. Of course, we need to have that call light in reach, even though the client may not remember to use it. If it's not within their reach, there's no way that they can use it, whether they remember or not. Frequent reminders to call for help to get out of bed. Of course, they need to be reminded, reoriented frequently. Bed rails up at all times. No, this is going to be considered a restraint. We would not do that. Use of the gait belt to ambulate. Of course, we would use that gait belt. It's going to help ensure that uh, we have something to hang on to instead of the client to help in case of a fall. We can help keep them from hitting the floor. Chemical sedation. Once again, restraint. This is a restraint, and we would not do that. Plus, it would probably increase the confusion. And frequent reorientation. Yes, we want to reorient the client as often as necessary to make sure that they know where they're at and what's going on. So the nurse anticipates the healthcare provider prescribing the following interventions. Select all that apply. Would this client require IV antibiotics? Very possibly. Um, Oral antibiotics may also be used, but IV antibiotics will definitely treat the issue quicker. Subcutaneous anticoagulants. No, we would not need to do that. Handheld nebulizers. Yes, we can get that bronchodilator, uh, etc., down into the lungs better with the handheld nebulizers. Fluid restrictions. No, we don't want to restrict fluids because restricting fluids can dry the client out even more, and doing this can cause those secretions to become even stickier and thicker and more difficult for her to expectorate and increases the risk of infection. Oxygen, 2 to 4 liters per nasal cannula. Yes, her oxygen saturation was below 90. We definitely need some oxygen on her. Nicotine patch. Yes, this client is a smoker. We do not want her smoking. So we're going to put a nicotine patch on her to help control those cravings and hopefully encourage her to quit. Small frequent meals. Yes, we want this client to be taking in enough calories to be able to maintain a body weight, which she was 5'10" and weighed 120 some pounds, which is probably pretty thin. So we definitely want to get some good nutrition going in, protein and some complex carbs going in. Antipyretics. Well, this client was not exhibiting a fever, so it would be not appropriate for this particular client at this point. Okay, so indicate which of the following assessments indicate to the nurse the interventions that were effective. An SaO2 of 92%. Yes, we were sitting in the 80s, so getting it above 90 is going to be terrific. Uh, and this client also, with her history of chronic bronchitis, probably has COPD, so 92% is probably really good for her. Alert and oriented times 3. Yes, she was confused. She was alert only to herself or oriented only to herself. So making sure that she is oriented times 3, this is really good. Infrequent cough, productive of green sputum. No, we've improved her cough, but she's still coughing up that green sputum, so that is not an improvement. Poor appetite? No, this is not an improvement either. Temp of 97.9. Well, she was afebrile to begin with, so, really it is not related at this point. White blood cell count of 10,900. Yes, we were over 15,000 when we started. We've definitely made some improvement there. Heart rate of 110. No, no, that's still too high. No crackles auscultated. Yes, most definitely shows an improvement. So, and how about steady gait? Yes, we uh, initially her assessment stated that she almost fell going to the bathroom the previous night. So she now has a steady gait. That is definitely an improvement. Okay, not sure if we can hear these lung sounds, but we're sure going to try. There we go. Okay, so we have a client that takes a bronchodilator by inhaler and tells the nurse that she feels jittery and that her heart pounds after she takes the medication. The client usually has 2 cups of coffee in the morning and is wondering if it's the coffee or the medication that is causing these symptoms. How should this nurse respond? Well, first of all, we need to explain that the bronchodilator will relax smooth muscle in the airways, but it does cause some central nervous stimulation, which affects the heart rhythm and produces tachycardia or tremoring. Excessive caffeine should be avoided when using bronchodilators because it can increase that central nervous stimulation. Um, So, in all honesty, the nurse should tell her that the side effects are not unusual, but if they cause discomfort or worsen, the client should contact her provider. So, six of one, half a dozen of another. It probably is the medication, but it could definitely be the coffee because caffeine is a stimulant. Some signs of respiratory disorders are subtle and require non-invasive methods to detect. What are signs that might lead a nurse to suspect a respiratory disorder? Well, there are several different things, such as a rapid or slow breathing. Those can both be signs of hypoxia. Flaring of the nares is a common sign of air hunger. The nurse inspecting the lips, tip of the nose, top of the auricles, the gums, the areas under the tongue. Those can also reveal inadequate tissue oxygenation if those areas are blue in tint or cyanotic. If the nurse observes pursed-lipped breathing, this can signal that the client's attempt to decrease dyspnea by slowing down those respirations. Inspection of the pharynx for redness or the tonsils for exudate or enlargement can also help detect potential respiratory infection. We can look at the trachea to see if it is midline or is it deviated from one side to the other. That can indicate a large area of atelectasis or potentially a pneumothorax. We also see the deviated septum with a tension pneumothorax. A tension pneumothorax, basically we do have that leaking and collapse of part of the lung or the entire lung. But if you remember, I talked about the vented dressing. That vented dressing is taped on three sides, so every time the client exhales, then the client is letting some of that air in the chest escape. But if we seal that completely up, and it does not allow that air to escape, then that air can just continue to build further and further and further, or we don't cover it at all. It allows the air to build up, and it's going to not only collapse that lung, but then the amount of air is then going to start pushing the other structures over further and further to the opposite side. And this is what we call the mediastinal shift, where the heart and the other lung get pushed way over to the other side. And we can see that reflected at times if the trachea is pushed over to the other side. So instead of being right down the middle of the neck, it is off to the right or off to the left. A nurse can auscultate also for that pleural friction rub or any adventitious lung sounds, which if you remember are going to be basically any abnormal sounds. And sometimes abdominal distension. This does not allow the client's diaphragm to fully expand and interferes with the filling of the lungs with air, which can also lead to shortness of breath. Those are just some of the signs. So we have a 30-year-old man that's having an asthma attack, presents to the emergency department with dyspnea, the use of accessory muscles to breathe, and audible wheezing. This patient receives an albuterol nebulizer for treatment. For which complication should the nurse monitor this client? First of all, the client, if he has a history of asthma, they frequently are going to have the rescue inhalers. And that rescue inhaler is often for example, albuterol. So if we have a client come in who has been using their rescue inhaler and they've not had any relief, or maybe they even have a nebulizer machine at home and they have albuterol that they can put in it. If they have been using that at home and they've not had relief, they come into the emergency department. Would we still give them albuterol inhaler or nebulizer? Yeah, we would do that. Uh, you never know. Sometimes that one more dose is going to be what it takes to help relieve symptoms. So we would definitely do that. So complications that we're going to monitor for in this client. This gentleman may be having bronchospasms in addition to those narrowed airways. If we don't treat it, it can lead to more serious issues such as right-sided heart failure, pneumothorax, acidosis, respiratory or cardiac arrest. Repeated episodes over time do cause a variety of complications, and this includes enlargement of the bronchial smooth muscle, thickening of the tissues in the airways, hypertrophy of the mucus glands, air being trapped in the alveoli, and hyperinflation of the lungs. And in case you all aren't aware, people can die from asthma. It happens all the time. So we should never minimize someone's symptoms. The assessment of a client's respiratory function should include a review of age-related anatomy and physiology, their lifestyle conditions that affect other areas of the body, and their cultural attitudes. When we collect data from a client with a respiratory disorder, what information should a nurse obtain about the client's current health and lifestyle? Okay, so remember those age-related changes. Remember, they can have some muscle atrophy, which would include some rigidity in the chest muscles, so they're not able to fully expand their lungs. That can also affect the larynx, the pharynx, and the position of the trachea. They have a decreased lung elasticity uh, and a flattening of the diaphragm. All of those age-related changes can reduce the chest movement and the ability to inhale or exhale, and that results in a less effective cough, which increases the risk for infection. It also leads to decreased ability to respond to stress and produce pain. It also produces fatigue, palpitations, cough, fever, sweating, or nausea. And medications can affect the respiratory system regardless of age. Exposure to any respiratory irritants, pathogens, and toxins. And remember, that also includes secondhand smoke at home and at work, can also damage respiratory health. The nurse should be aware that there's different cultural attitudes, such as beliefs and practices about smoking, that might affect a person's risk for respiratory problems and the likelihood of responding to treatment. Trauma to the respiratory tract needs to be considered also, along with a review of the other symptoms that might contribute to or affect respiratory problems. Those symptoms can include fatigue or weakness, fever, chills, night sweats, earaches, sinus pain, sore throat, edema, dyspnea, and orthopnea. Orthopnea is going to be basically shortness of breath when we're lying down. Okay, so how does the routine use of a peak expiratory flow rate meter benefit that asthma client? This is going to help the client monitor the level of their control, basically telling us, do we need to do anything different? Do we need to adjust their treatment that day? Or do we need to contact the provider or go in to see the provider? A client tests positive on a Manto tuberculin skin test. What would cause a positive test and what are the implications? Well, we know that testing positive on the Manto indicates that there is a need for further evaluation of the client, but it does not necessarily mean that the client has active tuberculosis. Rather, it only means that the client's body tissues are sensitive to tuberculin. This could indicate that the client was exposed to the bacillus at some point in time. But once a person reacts positively to a Manto test, they will always react to that test. The physician may order chest x-rays or sputum cultures or blood tests for further evaluation. Now we have a client diagnosed with pharyngitis 4 days earlier and is now calling to report increased throat pain. What assessment questions are we going to ask that are going to help us guide the client's care? Okay, so, we need to know, how long has this been going on? Anything make it better? Anything make it worse? Are you having upper respiratory issues such as nasal congestion or cough or sinus pressure? Because it may be that we need to treat with an antibiotic in order to help improve that drainage. If we have that drainage, then it can continue to drip down the back of the throat and really irritate the throat, causing that irritation. Have you been around anyone who's been sick lately? And if that's the case, then maybe they have caught an infection from someone, potentially strep throat. Have you had a fever? Are you coughing anything up? What types of treatments have you done at home that may make this a little bit or help guide us in the treatment that we're after, etc. So now we have a 15-year-old client that goes to a provider's office with his mom for a scheduled physical prior to starting competitive sports. He does have the sniffles and a slight cough, and his mom asks for an antibiotic that might knock out the bug right away and not interfere with sports or infect teammates. The provider will diagnose a common cold and offers over-the-counter prescription medications to relieve those symptoms. As the nurse is reviewing the medications with the client and the mother asks why her child wasn't given antibiotics. What might the nurse tell the mother? Remember, the common cold is caused by the rhinovirus. It is a virus, so antibiotics are not going to be useful for treating a bacterial antibiotics are used to treat bacterial infection, and since it's a virus, it's not going to really help. The best preventative measure is going to be that good hand hygiene. Client needs to get plenty of rest, increase fluid intake, and eat that well-balanced diet. Taking some antipyretics if there's a temperature, analgesics for generalized discomfort, and over-the-counter antihistamines can help dry out some of that the sniffles, that runny nose. A 78-year-old woman is admitted to the hospital with viral pneumonia. Problems include inadequate oxygenation and inadequate nutrition. Her vital signs: temp of 103.5, heart rate of 98, respirations 28, blood pressure is 160 over 94. Lung sounds are clear on auscultation. She states she's got shortness of breath and tires very easily. Her chest pain is aggravated by coughing, and she has a history of hypertension and congestive heart failure. She takes a diuretic and ACE inhibitor for these two conditions. So what problem should the nurse plan to address first? The first one should be that inadequate oxygenation. Remember your ABCs. We definitely need to be addressing that before anything else. And when you look at your ABCs, if we do not have an open airway, so starting with A, if we don't have that open airway, does it matter if they're breathing or not? No, because if they don't have an open airway, those respirations are not going to get down to the lungs. Does it matter if they have good circulation or good blood pressure if they don't have breathing or an open airway? No, because if they don't have that open airway and they're not breathing, they will not have a heart rate for very long. So does this client exhibit any signs of hypoxemia? Yeah. I mean, look at the tachycardia, the restlessness, and the tachypnea. All of those are compensatory mechanisms in which the body is trying to increase the amount of oxygen that's circulating throughout the bloodstream. What nursing action is indicated regarding this client's temperature? This is where we're going to look at some of our non-pharmacological issues in addition to giving some antipyretics. Maybe do the tepid, TEPID sponge bath, where it's more of a room temperature, so it's not real hot and it's not real cold. We want to be careful, though, when we do that, to not induce shivering, because if we induce shivering, that is the body's way of trying to warm itself up when it's cold. And we already have a temp of 103.5. We don't want to be increasing that any further. Okay, we have a 58-year-old female that has a medical history of COPD from chronic bronchitis. She's visiting her primary healthcare provider for a 6-month checkup. The nurse begins a comprehensive respiratory assessment by asking the client about her ADLs and dyspnea. She replies that she does get short of breath after climbing a flight of steps to her bedroom, or if she has to walk uphill anywhere. She says, as long as I can walk on a flat sidewalk, I can walk forever if I go slow. So, we need to assess this client's respiratory status with auscultation. How do we do that? Well, we definitely want to set them up. And then remember, we start at the upper chest, go from side to side, listening to at least 3 places on each side. Then we're going to listen laterally and listen posteriorly. So the client is a 45-year-old male that's been diagnosed with Guillain-Barré syndrome and is in intensive care unit as paralysis of the lower limbs continues to progress upwards to the chest area. Currently, this client is using a simple face mask to ensure adequate oxygenation. Let me tell you about Guillain-Barré. This is a disease process that starts off with some significant weakness that works its way from the feet all the way up to the head, and then as the disease process begins to resolve, then it will go from the head all the way back down to the feet. We can have extreme weakness up to and including some paralysis. So, this can be pretty significant, but people usually are going to recover from this. It just might take a while. So to ensure safety, comfort, and adequate oxygenation, making sure that we're not using any petroleum-based products such as Vaseline to keep the lips moist or the nose moist. Uh, Oxygen is very drying, so we need to use something, but don't use Vaseline. It supports flame, and so does oxygen. We want to make sure that if we're using a cannula that the nares are not getting irritated. We want to make sure that uh, the ears are not becoming irritated from the cannula. Making sure that we're assessing the respiratory pattern, the respiratory rate, the lung sounds, oxygen levels, etc. So this client at 1 a.m. was resting quietly with his eyes closed and had no difficulty breathing, but the nurse notes that the respirations are now 8 respirations a minute, which is a change from the assessment 30 minutes ago. So how do we address this? Well, first of all, we have a change in client status. We have to address the client's vital signs. We need to re-auscultate the lungs, and we need to reassess the respiratory status. What's the oxygenation level? What's the respiratory pattern? Are they dyspneic? Are they using those accessory muscles, etc.? And then we definitely need to be calling the provider. We'll probably be getting some arterial blood gases to determine the oxygenation level and CO2 level, etc. We also need to look at the level of consciousness and confusion, if there is any confusion. And as a result of this paralysis involving this client's lungs, this client is going to end up with a tracheostomy and be placed on a ventilator until that paralysis resolves. How do we assess a tracheostomy? Well, once again, we're assessing lung sounds. We need to make sure that that airway is open and patent, so we're assessing secretions. How well are they breathing? How patent is that tube? Are they having any pain, etc.? Okay, now we have a 38-year-old male that comes to the provider with a cough that just won't go away. His cough has been dry and hacking intermittently for the past 2 to 3 months, not taking any medications. Blood pressure is 134/76. Heart rate is 88, temp is 98.4, respiration's 24. Oxygen saturation is 97% on room air. He's 5'11" and weighs 190 pounds. So, what are some additional questions that you would ask to evaluate this client's cough? Well, what is the quality of the cough? How frequent is the cough? Is there anything that sets the cough off or anything that makes it better? Does he cough anything up? And if he does, what does it look like? How much is he coughing up? Any medications that he takes to help improve it? What information do you need to obtain as part of a smoking history? Well, first of all, has he ever smoked? If he is no longer smoking, did he smoke at one point, and how long did he smoke? How long ago was it that he quit? If he currently smokes, how much does he smoke? How long ago did he start smoking? How much does he smoke a day? Even what type of cigarette do you smoke? These days, we not only have the traditional cigarettes, but we also have the cigarettes that have no filter, which increases the toxins that are inhaled. We also have cigarettes that are menthol or flavored. Those also increase the toxins. Um, and we also have the vaping, the e-cigarettes. So definitely important to find out what the client smokes. And that can also include cigars and pipes. We also need to know about chewing tobacco or smokeless tobacco products. If they don't smoke, are they exposed to secondhand smoke? And if they do smoke, have they ever made any effort to quit? Any health history that we need to obtain from this client? Well, we need to know, are there any other symptoms, including pain, orthopnea? Remember, orthopnea is difficulty breathing when they're lying down. Dyspnea, exercise-induced or exercise intolerance, the ability to participate in usual activities. Is there a relationship between the symptoms and activity levels? Any exposure to fumes or toxins at work or home? Any changes in weight, nutritional intake? What's the vaccination status? Routine exercises, recent travel, alcohol use, medication use? What are allergies? History of asthma, pneumonia, respiratory infections, COPD, etc. Okay. You make sure that there's nothing more that I want to point out for this guy. Oh, yes, there is. What type of diagnostic tests might we order, and what would each one of those tests tell us? Well, we might do a sputum culture. It can let us know if there is a bacterial infection going on. A chest x-ray can let us know if there is an abnormality in the chest, such as a lump or a tumor, collection of fluid, consolidation, etc. Pulmonary function tests, or PFTs, can detect any alterations in lung volumes and airflow. Skin testing can let us know if there's any allergies or tuberculin infection. Exercise testing can also let us know the client's exercise capacity. Okay, we have a 55-year-old man that is coming into the healthcare provider with difficulty breathing that's gotten progressively worse over the past couple of weeks. Has a history of hypertension and is currently taking furosemide and lisinopril. He states he's had some shortness of breath for the past couple of weeks, and at first it was just with activity, but now it's gotten worse and is present even at rest. He did start smoking at age 18 and has smoked one pack per day for the past 37 years. Adds that he has cut down on his smoking the past week and is only smoking half a pack a day. His blood pressure is 140 over 88, heart rate is 90, temp is 98.7, respirations are 22. Oxygen saturation is 90% on room air. His respirations are labored, has frequent productive cough with yellow sputum. Breath sounds reveal distant sounds in the right lower lobe and clear in all the other lobes. Has dullness to percussion of the right lower lung lobe. And chest x-ray shows a 2.5 centimeter lesion and pleural effusion in the right lower lobe. So, what is a pleural effusion? Pleural effusion, remember, is going to be an abnormal collection of fluid, usually in the lining of the lungs. The healthcare provider will perform a thoracentesis to relieve this client's dyspnea and to have this fluid analyzed for diagnostic purposes. So, what is the procedure for a thoracentesis? Well, that thoracentesis, remember, we'll have the client sit on the edge of the bed. They're leaning over a bedside table. The client or healthcare provider will be behind them, numbs the area, then inserts a needle into the intercostal spaces or between the ribs, using X-ray or sonography to help identify the particular area. And then they can actually aspirate that fluid using a syringe, or they can aspirate that fluid by putting it in that pressurized vacuum bottle, and it will pull fluid out. Okay, so the results of the thoracentesis revealed that there is malignant cells in the pleural fluid, and the client then has a CT scan of the chest, brain, and bone to evaluate the exact location and size of the lung mass, in addition to checking for any mediastinal or lymph node involvement or metastatic disease. The results of the CT scan just show that 2.5 centimeter lesion in the lower lobe of the right lung, with no evidence of mediastinal or lymph node involvement or metastasis. So the client undergoes a thoracotomy with a right lower lobe lobectomy. In other words, they're just removing that right lower lobe. After surgery, he's admitted to the surgical step-down unit with a chest tube. So what is the purpose of a chest tube? This is going to drain air or fluid, or it's going to help allow a lung to re-expand. How are we going to maintain that chest tube drainage system? Well, there's some important guidelines. First of all, we need to keep that drainage system upright and below the chest level. This will help maintain a water seal and help prevent drainage from spilling over into different collection chambers. We're also need to make sure that all connections of the chest tube are tight and well secured. We also need to keep all the tubing loosely coiled below the chest level to promote drainage. Then we need to observe for fluctuations. This is called tidling. In other words, every time the client takes a breath and exhales, we should see that water level in the water seal chamber going up and down, up and down. We're also looking for bubbling in the water seal chamber. Initially, when a chest tube is placed, until that lung has re-expanded or all of that air has been removed, we will see some bubbling. But once we have gotten it re-expanded and we removed that air, then we shouldn't see bubbling any longer. So after that happens, if we begin to see bubbling again, that means that there might be an air leak in the drainage system or on the client side. If we don't see that tidling, it means that there might be a blockage in that drainage system. So if a chest tube drainage system breaks, we need to be doing something very quickly, so we don't allow air to get back into the chest cavity. We can do this a couple of ways. Most people who have a chest tube are going to have chest clamps or chest tube clamps placed in their room so they're easily accessible, just in case there is a leak in the drainage system, and we can just use that clamp and clamp off the tube to prevent air from getting back into the chest cavity. Or we can take the end of that tube and just put it in a cup or container of sterile water. Again, that does not allow air to get back up that tube into the chest. One thing I want to point out is if we do have a pneumothorax or a leakage in that chest drainage system, sometimes that air can get into the tissue of the client's chest or their neck or their upper arm, etc. And as you are assessing, you feel or hear this crackling and popping going on uh, as you're running your fingers over that tissue that has these little bubbles of air. This is called subcutaneous emphysema, and it is a common thing seen with a pneumothorax. So when it's time for the chest tube to be removed, this is when the lung has fully expanded or we're no longer getting any drainage or air out. We often will disconnect from the drainage system and we'll put what we call a Heimlich valve on the end of the chest tube. This is going to allow air to escape out the tube if necessary, but does not allow any air to come back in. If the client tolerates that well for a day or two, then it's time to remove that chest tube. Usually that chest tube will be sutured into the chest to prevent it from migrating. So we need to snip that suture. We're going to have Vaseline gauze readily available because we don't want any air getting through that dressing. So as we get that suture removed, we have the dressing available right in our hand. We tell the client to hold their breath, or we ask the client to bear down like they're going to have a bowel movement. That's called the Valsalva maneuver. This helps prevent air from getting back into the chest while we take that tube out. So as soon as that tube comes out, we slap that dressing on the insertion site. Then we will allow the client to go ahead and breathe. We will do some subsequent x-rays just to make sure that that lung stays fully expanded or we don't have a reaccumulation of fluid. So question, which of the following is not true of the effects that can occur with repeated episodes of status asthmaticus? The correct answer is C, underinflation of the lungs, because usually we're going to see hyperinflation of the lungs. Which of the following is not an age-related change in the older client? Epistaxis is less common in older people. A therapeutic measure that consists of percussion, vibration, and postural drainage is called? This is chest physiotherapy. A foreign substance that's carried through the bloodstream is called? This is an embolus. A thrombus is just going to be the clot. When it travels, we call it an embolus. Re-expansion of a collapsed lung may be accomplished by a chest tube. Acute respiratory distress syndrome may develop from how many hours after some trauma to the lung? Your book says 8 to 48. So the closest answer here is going to be B, 6 to 72. A possible dangerous consequence following treatment of an open chest wound is? This is B, attention pneumothorax. Attention pneumothorax is going to be where we have the leakage of air in the chest from a pneumothorax. This is why we use the vented dressing to allow air to escape. If we don't have that vented dressing, or if we have no dressing over an open chest wound, air can get in, but it may not be able to get back out of the lung. So if we have an occlusive dressing on there, this is what will happen. Air is able to get into the chest cavity, but it does not escape. So it just continues to build and build and build, and it takes up more and more and more space in the chest. And as it does that, it's going to shift all of the organs in the chest from one side to the other side. This will include the heart and the remaining lung and all of that vasculature that is associated with it. And it can become so severe that it can be life-threatening. If we see the tracheal deviation in the client, in other words, it's not midline, not running down the middle of their anterior neck, but it's off to one side or the other, this is a sign of a tension pneumothorax. And it means that all of the structures are being pushed off to one side. And once again, life-threatening situation going on there. We have to take care of this quickly. Airway dynamics refers to B, a client's ability to inhale or exhale by force. Which of the following surgical procedures performed for lung cancer clients involves the removal of an entire lung? This is the pneumonectomy. That removes the entire lung. The lobectomy removes just one of the lobes. How long after the early phase of an asthma attack does the late phase begin? And this is not something we discussed, so I really don't expect you to know it. The correct answer is C, 5 to 6 hours. The condition characterized by increased mucus production and chronic cough persisting for at least 3 months of the year for 2 consecutive years is, this is the definition of chronic bronchitis. The condition involving abnormal enlargement of air spaces beyond the terminal bronchiole is called, this is emphysema. Cor pulmonale is the term used to describe, this is right-sided heart failure. We'll discuss this in a little bit more detail next week when we discuss the cardiac system. And chronic obstructive pulmonary disease is the leading cause, which leading cause of death in the United States? The correct answer is D, the 4th leading cause of death.